Hi there, and welcome to this video lecture brought to you by Atoza. My name's Garth. In this lecture, I'm going to be discussing the management of anaphylaxis for the training anesthetist. So I've been involved in anesthetics now for about 12 or 13 years, and I've already come across a few anaphylactic reactions. And I want to share these anecdotes with you just to put anaphylaxis into context. And while I'm sharing them, try to imagine that you're the anesthetist and you're involved in these situations. So the first one is you are giving anesthetics at a day clinic for minor plastic surgery procedures. And there's a wide range of patients on the list. There's some young, healthy patients, and there's some older, frail patients with quite significant comorbidities. But it's low-risk surgery that's done predominantly under local anesthetic with just a little bit of sedation to handle the initial injections of the local anesthetic. So towards the end of the list, you have an elderly patient, say in their 80s, with a history of ischemic heart disease, a bit overweight, and mild cardiac failure. And you start your sedation just like any other sedation that you do there. Give 1 or 2 milligrams of midazolam, 5 micrograms of sufentanil, and then your antibiotic, which in this case was co-amoxiclav. And immediately the patient becomes distressed. They start to have stridulous breathing, they become confused and disorientated, hypoxemic, and the blood pressure drops to 60/20. You're at a day clinic. There are no other theatres, there are no other anaesthetists around. It's just you and the theatre staff, and you've got to manage this situation now in an elderly patient with multiple comorbidities. The next scenario is you are working in the intensive care unit, and there's a polytrauma patient that comes in with some rib fractures and a femur fracture, and the patient's booked for theatre, and you're part of the team to now prep the patient and try optimize them for theatre. There's about an hour delay before the patient gets to theatre. So you see the patient in the ICU and the systolic blood pressure is around 90 and the heart rate's around 120. So you think, I think this patient might be behind on fluid, and you choose to give the patient a colloid fluid bolus, 500 ml of gelifusin. And as soon as the infusion starts, the blood pressure drops to 40/20 in a patient that is already behind on fluid and a polytrauma patient. The next scenario is you're doing a routine anesthetic, a young healthy lady for a minor gynae procedure, laparoscopic procedure that's going to need intubation, ventilation, and muscle paralysis. You do your normal intravenous induction, and after giving the rocuronium, you discover after a minute or two of bagging the patient that the chest is tight. You're no longer able to mask ventilate the patient. You intubate the patient. It's a grade 1 view. You're certain that your endotracheal tube is in the right place, and you try to ventilate, and there is tight bronchospasm. You then notice the patient's also got an urticarial rash on her arm, and so she's having anaphylaxis with tight bronchospasm. And then the last scenario is you complete an anesthetic in a similar sort of patient, middle-aged, not a big deal. Patient required an endotracheal tube and paralysis for the case. At the end of the case, the nerve stimulator is not available. You take a shortcut and you reverse the patient without checking their train or 4 count. Extubate them, take them through to the recovery room. They're looking okay, but they're taking some rapid shallow breaths, look a bit weak, and so you think perhaps this patient is not adequately reversed. And you give the wonder drug, Sugamidex, to quickly reverse any residual paralysis from the rocuronium. And it works amazingly. The patient regains their strength, looks good for a minute or two, and then suddenly becomes hypoxemic, tachycardic, and hypotensive. And you have to now manage this patient in the recovery room. These are all examples of anaphylactic reactions. Some of them have occurred to me in my theatre, but others have occurred in the theaters around me while I've been going about my business. And I include them just to make anaphylaxis feel real to you. Anaphylaxis is a rare event, but when it does happen, it can be immediately life-threatening. And again, when I was training and I thought about complications, I always pictured them in a serene, controlled environment with healthy patients where everything was going well, and then I had a complication. And that's not how it works in the real world. These complications happen at any time. You can have anaphylaxis during open heart surgery, during brain surgery, on a neonate. You can have it in a polytrauma patient, and then you can also have it in the most routine, stable, seemingly minimally invasive anesthetic and surgery like a sedation in a day clinic. It can happen to anyone, anytime, anywhere. And as anesthetists, we have to be prepared to manage it. So that's why we've included this video talk, and we're going to get into the details of how to effectively manage anaphylaxis. Okay, so let's tackle this topic in a series of questions and then some answers. So the first question is, why does anaphylaxis occur? So anaphylaxis occurs when foreign material, which we call an antigen, is recognized and binds to the antibody in the body called IgE antibody. And this is found on plasma basophils, so basophils that are circulating in the blood, and then tissue mast cells. These are both forms of white blood cells, and they're part of your immune system. So the antigen binds to the IgE antibody, and this causes activation and degranulation of the basophils and the mast cells, which means that they release their pro-inflammatory mediators. And these pro-inflammatory mediators create an over-the-top or exaggerated or hypersensitivity reaction. And that's why anaphylaxis is called an immediate type 1 hypersensitivity reaction. There are other types of hypersensitivity reactions. You might remember that from medical school, but we're not going to be discussing those today. So an important point to remember here is that a small amount of antigen or allergen is able to stimulate a full-blown anaphylactic reaction. It's not dose-dependent. And then the harmful effects that we see in anaphylaxis are because of these mediators that are released, and they cause systemic vasodilatation, so dilatation of your arteries and your veins, which decreases your peripheral vascular resistance and causes hypotension. It also causes venous pooling and decreased venous return to the heart with decreased preload and decreased cardiac output. In addition to this vasodilatation, it's really important to remember this, it also causes leaking capillaries systemically throughout your whole body. And you get fluid leak from the intravascular compartment into the tissues, and that causes acute hypovolemia, and that contributes significantly to the hypotension. These mediators can also stimulate smooth muscle spasm in your airways, and that's called bronchospasm, and that looks like an acute asthma or bronchospasm attack. And then the leaking capillaries can cause mucosal edema, and that can cause airway edema, and it can also cause swelling of the eyes, and it's what causes the erythematous and urticarial rash that you may see on the skin. So the next question is then, well, how do these IgE antibodies recognize the antigen? And must there have been a previous exposure to the antigen for anaphylaxis to occur? Well, the answer is yes and no. So certain antigens require pre-exposure before an immune response or an anaphylactic response can occur. And this process is known as sensitization. And this is certainly the classic way that immune responses occur, and also the classic way anaphylaxis occurs. Previous exposure, sensitization, and then on repeat exposure, this hypersensitivity reaction. And I guess an example here would be a bee sting, where on your first bee sting, you might have just a mild reaction to the bee sting, but then on subsequent bee stings, you can have much more severe reactions. And there are many people that actually have escalating responses with each subsequent bee sting. And those patients need to carry adrenaline around with them in what's called an EpiPen for self-injection. So that's an example of anaphylaxis that occurs after sensitization. But there are also many cases of anaphylaxis that can occur on first-time exposure. And the big one to remember here for anesthetists are the non-depolarizing muscle relaxants, specifically rocuronium. And there are varying theories as to why rocuronium can cause a reaction in someone who's never been exposed to it before. And one of them is that people are being exposed to similar shaped antigens in our normal daily lives, in our diet and in our normal living. And then we have cross-reactivity between those antigens and the rocuronium antigen. And then those patients can have anaphylaxis on first-time exposure to the rocuronium. So again, this comes down to this idea that anaphylaxis can occur to anyone, anytime, anywhere. Even someone that's never had an anesthetic before, never been exposed to those drugs before, can have an anaphylactic reaction. So how common is this terrifying perioperative event? Well, it's difficult to know for certain because there's definitely underreporting of events, especially the lower grade events. But from my reading, it seems like it occurs in up to 1 in 10,000 anesthetics. So if you remember, I said at the beginning that I've been involved in anesthesia now for 12 years. I don't think I'm quite at 10,000 cases, but I've already had 3 anaphylactic reactions that I've been personally involved in, and there have been at least another 3 to 5 that have happened over this period in the theaters around me while I've been working. So it is definitely something that is happening frequently and that we need to be aware of. Okay, so how do we now recognize anaphylaxis clinically? Because when a patient deteriorates acutely in theater or in the recovery room or in the ward, there could be a number of things happening. It could be a cardiac arrhythmia, it could be a myocardial infarction, it could be a pulmonary embolus, it could be the development of sepsis and hypertension from that. So the differential for intraoperative collapse is quite big. So how do we recognize anaphylaxis? So one component is the time relation or the temporal nature of the events. So there is exposure to an antigen, and in our situation, this is a drug. We administer a drug to a patient, and then there is an acute change in the patient's condition. And we see anaphylaxis like that in theater because we are administering intravenous or intramuscular drugs. And in those scenarios, the event usually happens within a couple of minutes. Although there are reports of reactions occurring later, up to 2 hours or even longer, but the classic reaction in theater with an intravenous drug is quite quick. An example of an anaphylactic reaction in theater that tends to be delayed is that of latex allergy. And the classic thing here is for the patient to present with allergic or anaphylactic symptoms about 60 minutes after exposure to the latex allergen. So that's the first component in recognizing anaphylaxis, that sort of temporal nature of the events. Next, it's the signs and symptoms of anaphylaxis. And we'll go through those now, but they depend largely on the context. So is the patient under general anesthesia and asleep? We'll recognize anaphylaxis there differently to patients that are awake in theater under anesthesia or are awake in the recovery room or in the ward. So let's look now at how we might detect anaphylaxis in a patient having a general anesthetic. So the first thing is you might notice a erythematous rash or an urticarial rash. This may not actually be seen in patients that are having a severe form of anaphylaxis with cardiovascular collapse, because the tissue perfusion to the skin is so poor that you don't see the fluid leak and the histamine effect, and the rash might only actually appear later during your resuscitation when you restore the cardiovascular parameters. But rash is definitely a warning sign of anaphylaxis. Next, we can have hypotension, and this can either be with tachycardia, which is the classic form of shock and underperfusion and systemic vasodilatation and decreased preload, hypotension with tachycardia. But we can also have hypotension with bradycardia. And that's thought to be because of the significant fluid leak that I told you about, the fluid leaking into the tissues, and we get acute ventricular underfilling. And then that stimulates a Bessel-Jarisch reflex, where we have bradycardia to allow the ventricle to actually fill with a reduced preload before the next contraction. So hypotension with tachycardia or hypotension with bradycardia. We can see cardiac arrhythmias, we can see myocardial ischemia, there can be a cardiac arrest, and then we can also have difficulty in ventilation, which will have the pattern of acute bronchospasm. In the talk on ventilation, I go into detail on how to detect bronchospasm and how to manage bronchospasm. And then we can also see mucosal edema, and that may present as a swollen conjunctiva and then airway swelling of the lips, the tongue, the pharynx, the mucosa around the arytenoids and the larynx. Can be significant airway swelling. So that's anaphylaxis in the asleep patient under general anesthesia. For patients that are awake either in theater or the recovery room or the ward, they may now obviously be able to communicate. So they may complain of an itchy rash, dizziness, a racing heart, palpitations, shortness of breath, a heavy chest, a tight airway, difficulty to swallow. They may complain of abdominal pain and nausea. And then when we assess them and examine them, again, we might find hypotension with or without tachycardia or bradycardia. We might see cardiac arrhythmias, myocardial ischemia, hypoxemia, cardiac arrest, stridor, airway swelling, chest wheeze, hyperinflation, all of those things we might see too. So the take-home message here is that we need to have a high index of suspicion for anaphylaxis so that we can act quickly. Okay, so the next question is, are all anaphylactic reactions life-threatening? So this is actually kind of a difficult question to answer. All anaphylactic reactions must be viewed as potentially life-threatening, meaning that even mild reactions can progress to severe reactions. But at the same time, not all anaphylactic reactions are life-threatening. Anaphylaxis is a spectrum of severity, and not all patients have all the signs and symptoms, and the severity varies from patient to patient. And that's why there's a grading system that we use for anaphylaxis, and that helps us in our treatment decisions. And it's called the Ring and Mesner scale, and there are 4 grades. We'll go through them now. For a grade 1 reaction, patient may have generalized erythema, extensive urticaria on the skin, and may or may not have angioedema. In the original Ring and Mesner classification, they don't specify the degrees of angioedema. So I've included some information here from other sources, and you can see that in the bold and italics, to clarify the different degrees of angioedema specifically. So in a grade 1 reaction, the angioedema would be swelling of the lips or eyes only. There would be no swelling of the tongue and no stridulous breathing. In a grade 2 reaction, this is a moderate reaction with multi-organ or multivisceral signs. Here the mucocutaneous signs would include generalized erythema or urticaria, but now the patient would have stridor or tongue swelling, but would not be in distress and would not have difficulty breathing from this stridor or tongue swelling. They could have moderate hypotension or tachycardia, and they may have moderate bronchospasm. They can also have gastrointestinal symptoms, which would be nausea and vomiting or abdominal pain. In a grade 3 reaction, this is now a life-threatening single organ or multi-organ event. So there can be life-threatening hypotension with tachycardia or bradycardia, with or without cardiac arrhythmias. The mucocutaneous signs here would include the urticaria and generalized erythema. But in terms of angioedema, the patient would now have severe stridor with distress, struggling to breathe, and possibly pooling of secretions. I've included this picture here taken from the Journal of Intensive Care Medicine, February 2012, of severe laryngeal edema. In this case, the larynx is intubated. You can see the endotracheal tube, but you can imagine that trying to intubate a patient with severe laryngeal edema like this would be extremely difficult. This is the type of life-threatening laryngeal edema that can occur in grade 3 anaphylaxis. The patient could have severe bronchospasm and hypoxemia, and they may also have gastrointestinal symptoms. And it's important to note here that the cutaneous features of erythema and urticaria may be absent in these patients initially because of the circulatory collapse, but the cutaneous features may appear after restoration of hemodynamic stability. And then a grade 4 reaction is where there is cardiac arrest from anaphylaxis. So one of the challenges in managing anaphylaxis is if we detect a grade 1 or grade 2 reaction, which are not imminently life-threatening, how do we know whether that's going to progress to a grade 3 or grade 4 reaction? And we'll discuss this later when we talk about treatment and managing the risks and benefits of giving adrenaline. And then also just to reiterate that in general, intravenous or intramuscular or mucosal exposure to antigen tends to result in faster and more severe reactions. And that's why in anesthesia, we see reactions that occur quite quickly after we administer a drug, and they're often more severe reactions in theater. Right. So the next question, which I hadn't actually thought that much about before I started this talk, was, can we predict who's likely to have an anaphylactic reaction and then change how we manage that patient? So the most obvious risk factor, and the one that we all know about, is patients that have had a previous anaphylactic reaction. Someone who says to you, I'm allergic to a drug, or I've had an anaphylaxis in the past. And then we obviously need to change the way we manage that patient, and we'll discuss later an approach to some of the more common allergies that I've come across in my practice. The next most obvious risk factor is exposure to the drugs that are known to cause anaphylaxis. And those tend to be the antibiotics, the non-depolarizing muscle relaxants, the colloid intravenous fluids, and latex. So if we're doing an anesthetic in a patient where they don't need a muscle relaxant and they don't need an antibiotic, their risk of anaphylaxis is obviously less than someone who is getting a muscle relaxant and getting an antibiotic, because now they are exposed to drugs that we know are more likely to cause anaphylaxis. Any drug can cause anaphylaxis, but it seems that some cause anaphylaxis more readily. Then there are also other risk factors. So for example, patients may be allergic to certain food groups, and that can have cross-reactivity with drug allergies. And the classic one is a latex allergy. And in patients who are allergic to avocado or banana or kiwi fruit or pineapple or papaya are more likely to develop latex allergy. There are other patients that are also more likely to develop latex allergy. Those are patients that require repeat catheterization and exposure to latex in urethral catheters. Those are known risk factors for latex allergy. One thing that I was not certain about is whether drug allergies are inherited or not, because I've had quite a few patients say to me, I'm not allergic to penicillin, but my brother or my sister or my parents are very allergic to penicillin. And so I did a small search on that. And according to the American Academy of Allergy, Asthma, and Immunology, allergies to medication or drugs are not inherited. Okay, so what are the main causative agents for anaphylaxis in the perioperative period? Well, we've just mentioned those, but one of the things that comes up in the literature repeatedly is to try determine which are the most likely agents in each country. And it differs from the UK to France to America. The ordering in terms of which is the most likely differs, but the sort of top 4 or 5 are the same across all of the countries. And I think that's the take-home message, that the main offending drugs are antibiotics. And because we give cefazolin as surgical prophylaxis frequently in theatre, cefazolin is the antibiotic that has got the highest reported allergy in theatre. And then the non-depolarizing muscle relaxants, of which rocuronium is the worst, and then the colloid intravenous fluids, and then a latex allergy. So those are the 4 main offenders that I come across in my reading. Right, so that was some of the background. Now we have to ask ourselves, how do we treat anaphylaxis? Well, the general principles in managing anaphylaxis are: the first step is to stop exposure to the offending agent. So stop injecting the medication or don't give further doses of the drug that you might suspect has caused the anaphylaxis. The next point is to place the patient in a supine position, and preferably with the legs elevated or in a Trendelenburg position. And that's to improve venous return to the heart and try to improve cardiac output and central perfusion. Initially, when I thought of this, I thought, maybe this isn't so applicable in theatre because our patients are in the supine position, but they aren't always in the supine position. We operate on patients in a beach chair position, in a lateral position, or in a prone position. In the recovery room, I certainly try to have my patients in a 30 to 45 degree head-up position so that their diaphragm can move nicely. So often our patients are not supine, and when they are having an anaphylactic reaction, we want to make them supine. Then the ABCs of resuscitation still apply. We want to assess the airway, the breathing, and the circulation, and we want to manage problems in any of those areas. But the one difference is that anaphylaxis is primarily a circulatory problem, or rather to say, if there is circulatory collapse, the patient is definitely not going to improve until you manage that circulatory collapse. And so the one change in the management from ABCs is to give adrenaline as soon as possible in the more severe reactions. So if you have a patient that has an acute deterioration and they are hypotensive and hypoxemic and they're having a stridor, your management needs to obviously focus on the airway and the AB part of resuscitation. But at the same time, unless you get an adrenaline dose in as soon as possible, that airway breathing level of consciousness is just going to get worse while you manage and focus that side, and you've left the circulation unattended. So the take-home message there is that you want to give adrenaline as early as possible. But we'll get into that in more detail just now. The next general principle is that we need to prepare for a large volume fluid resuscitation. And the literature that I've read has spoken of fluid deficits of up to 5,000 mils. And so we need to prepare to give fluid. And that might mean putting in a better intravenous cannula. It might mean getting a pressure bag that you can squeeze your fluid and get it in a bit faster. And you certainly want to have fluid available in theatre and start giving intravenous fluid. We're obviously going to need to give bronchodilators to patients that are having bronchospasm, and we're going to need to give them supplemental oxygen. And then the use of corticosteroids and H1 blockers and H2 blockers are part of most of the treatment protocols, but their use is a little bit controversial in that there's no science proving their benefit. So don't rush to give a corticosteroid or an H1 or H2 blocker, but during the management of these patients, we can give those drugs, and I think most people would give those drugs. So the treatment of patients having anaphylaxis depends to some extent on the severity or the grade of the reaction. So let's go through now some case scenarios looking at the different grades. So let's say we have a patient having a grade 1 reaction. Remember, this is a mucocutaneous reaction only. There's no bronchospasm, there's no hypotension or arrhythmias or anything like that. Just mucocutaneous, and it's a mild reaction. There's generalized erythema, there might be some urticaria, and then there may or may not be some angioedema, but it's mild and it's not life-threatening. These patients are stable. We can give them an antihistamine to try relieve the itch and take away the rash. And in a theater situation, we would want to give an intravenous antihistamine. The one that I would use is Phenergan, 25 milligrams, and I would give it slowly over 5 minutes, bearing in mind that it does cause some sedation. And then we'll give these patients hydrocortisone, 200 milligrams intravenously. These patients require constant monitoring to assess if they are deteriorating. And obviously we have our normal vital signs, so we can see heart rate, blood pressure, saturation. But the thing that I want to emphasize is to not miss worsening airway compromise. So to closely monitor the degree of angioedema and airway swelling. The use of adrenaline in these patients is a little bit of a gray area. So we know that if we delay giving adrenaline in patients that are having anaphylaxis, the outcomes are worse, they can progress to a more severe grade, and it can become a life-threatening situation. But there are some risks with adrenaline too, and we're going to get into those just now. So it's really balancing the risk of progression against the risk of adrenaline toxicity or adrenaline overdose. And given the target audience that this talk is aimed at, it's aimed at learning, training anesthetists in the South African context. And when we're in that situation, we're often working in under-resourced environments. And so my advice would be to err on the side of caution. So if you have young, healthy patients that have got a low risk of adverse effects from adrenaline, they've got no cardiovascular risk factors, they obviously don't have vascular disease because they're young and healthy, they haven't had major surgery with a high risk of bleeding, I would give adrenaline to those patients. I would give them intramuscular adrenaline, not intravenous adrenaline. Intramuscular adrenaline, 10 micrograms per kilogram. That is the dose across all ages, from neonates to 100 years old. 10 micrograms per kilogram intramuscularly, and you cap that dose at 0.5 milligrams. So most adults are going to get 0.5 milligrams of adrenaline intramuscularly stat. And you give it using a long needle into the anterolateral aspect of the thigh as deep as you can. In obese patients, don't worry if your needle doesn't reach the muscle. Just push the needle in as deeply as you can, aspirate to make sure that you're not in a vein or an artery, and inject in that position. So that's young, healthy patients that are having a grade 1 reaction. If you find yourself managing older patients or patients that have got more risk factors for things to go wrong with adrenaline overdose, then it becomes more difficult. In these patients, you could definitely make an argument for not giving adrenaline immediately, but watching and reassessing the patient, and if there's any further deterioration at that point, give the intramuscular adrenaline. So let's now move on to a grade 2 reaction. So as we said, this is a moderate reaction that involves multi-organ or multi-visceral reaction. So we have the mucocutaneous signs, the urticaria and the erythematous rash. We might have more significant airway swelling, but it's not acutely life-threatening. We can have moderate hypotension, tachycardia, with or without moderate bronchospasm, and there can be gastrointestinal symptoms. So these patients need adrenaline, and again, I would say we should be giving these patients intramuscular adrenaline, the same dose, 10 mics per kilogram, up to 0.5 milligrams intramuscularly stat. And we can repeat that dose every 5 to 15 minutes until the symptoms resolve. After giving the intramuscular dose, we can prepare for intravenous adrenaline boluses. Remember, these patients are stable, so we have time, there's no rush. We give the intramuscular adrenaline, we're watching the patient closely, and we can prepare in case the patient deteriorates further. So we can mix 1 milligram of adrenaline in a 20 ml saline syringe. That makes 50 micrograms per ml. We can label that syringe and we can have it ready. And we can also, if you have the facilities, set up an adrenaline infusion, 2 milligrams in 50 ml saline, and we'll be ready to start that infusion. So that if these patients deteriorate and their grade 2 reaction becomes a grade 3 reaction, we're ready to give further adrenaline intravenously. We also need to start giving these patients fluid, and I would start with a fluid bolus of 500 to 1,000 mils of ringers quite quickly, just to make sure that if they do progress and deteriorate, we've got them euvolemic from the start.
In addition to this, these patients also have mild to moderate bronchospasm, which we need to manage. And so if the patient is awake, we can nebulize that patient on 100% oxygen using a rapid-acting beta-2 agonist, such as salbutamol or phenobarbital. And then we can also nebulize them with ipratropium bromide. And then these patients may also have laryngeal edema presenting as stridor. Remember, in a grade 2 reaction, it's mild stridor, they are not distressed, and they are not having difficulty breathing. And to treat this stridor, we can do adrenaline nebulizations, and I would mix 1 milligram of adrenaline with 3 mils of saline and give that to the patient as a nebulization. In patients that are under general anesthetic, we're obviously unable to use the normal nebulizer, and then we would have to administer a rapid-acting beta-2 agonist down the breathing circuit or the endotracheal tube. And in the talk on the management of asthma and bronchospasm, which is in the ventilation complication talk, I go through how to use a metered dose inhaler to administer puffs down the breathing tube under general anesthesia.
These patients can also receive the hydrocortisone dose of 200 milligrams intravenously and a slow Phenergan dose of 25 milligrams intravenously. Right, so now let's talk about a grade 3 reaction. This is a life-threatening single organ or multi-organ reaction. Life-threatening hypotension with tachycardia or bradycardia, with or without cardiac arrhythmias. Mucocutaneous signs might be there or they might come later. Severe bronchospasm, and then gastrointestinal symptoms. So here we need to follow the ABCs of resuscitation, but as I said, we want to get our adrenaline dose in as quickly as possible. And then depending on the scenario, you can either give an intramuscular dose of adrenaline, the same dose again, 10 micrograms per kilogram, up to 0.5 milligrams. So you can give that intramuscularly every 5 to 15 minutes. But what's going to help the situation faster is if you now use intravenous adrenaline. So how I would give the intravenous adrenaline is I would dilute 1 milligram, which is 1 ampule of adrenaline, in a 20 ml syringe with saline, and that gives a 50 microgram per ml concentration.
And I would give boluses of 100 to 200 micrograms of adrenaline, depending on the blood pressure. So bearing in mind that this is a 50 microgram per ml solution, if I want to give 100 micrograms, I have to give a 2 ml bolus. And if I want to give 200 micrograms, I've got to give a 4 ml bolus. I would give this into a free-flowing intravenous line, and then I would try flush that in with at least 20 mils of the intravenous fluid. It's really important that we have our non-invasive blood pressure cycling every minute at this point. And if you can, keep your finger on the carotid pulse so you can see if there is a response. And if there's no response within 60 seconds, I would repeat the adrenaline bolus and possibly escalate the dose.
And I think there's no right or wrong answers here. If you underdose the adrenaline, you're going to be hypotensive for longer. If you overdose the adrenaline, you're going to see hypertension and tachycardia. So it's difficult to know whether to give 50 micrograms or 100 micrograms or 200 micrograms. If I saw a blood pressure of 40/20, I would give 200 micrograms of adrenaline, and actually I'd probably start chest compressions in that patient. I've read management protocols that have said that if the systolic blood pressure is below 50 in anaphylaxis, start chest compressions, because you actually need chest compressions to circulate the adrenaline that you're given, and otherwise it's going to take too long for that adrenaline to reach the heart and to reach the circulation. So very low blood pressures of systolics 40 or 50, I would give a 200 microgram bolus of adrenaline and start chest compressions until the blood pressure has improved. If the blood pressure is higher, systolics of 60 or 70, then I would give a 100 microgram bolus of adrenaline. Those are just thumb sucks. The take-home message is that you need to make sure that you dilute your adrenaline appropriately so that you know what you're giving. And if the blood pressure is very low, give 200 micrograms. If it's not that low, give 100 micrograms, and rather see hypertension than prolonged hypotension. Remember that hypotensive patients are going to have a reduced level of consciousness. They might be agitated. They're going to have hypoxemia, and then they're at risk of organ damage, brain, heart, kidneys, liver. So we don't want to leave patients hypotensive for a long period of time. Okay, so adrenaline boluses in grade 3 reactions. Then once the blood pressure is restored with your adrenaline boluses, then you need to start an adrenaline infusion. A single intravenous bolus of adrenaline is unlikely to be enough to break the anaphylaxis cycle. So we need to start an adrenaline infusion so that you have sustained exposure to adrenaline. And I would start with my standard mixture, 2 ampules, 2 milligrams, in 50 mils of saline, and I would run that starting at 20 mils an hour. And then depending on the blood pressure, we can then titrate that adrenaline infusion up or down, giving repeated boluses as needed.
Patients with grade 3 anaphylactic reactions are going to need more fluid than patients with grade 2 reactions, and I would start with a 2,000 ml fluid bolus of a balanced crystalloid solution given as quickly as possible. So one may need to insert a bigger intravenous cannula or connect a pressure bag to our vacuolator so that the fluid can run in faster.
But then also remember that they may require up to 5,000 mils of intravenous fluid during ongoing resuscitation. These patients may require intubation and ventilation, and that's for a number of reasons. So I've spoken about hypotension contributing to agitation, confusion, decreased level of consciousness, in which these patients are not going to be able to protect their airway against secretions and vomiting and aspiration, so they might need intubation from that point of view. They may also need early intubation because of mucosal edema of their airway.
This airway edema could be in the form of severe swelling and edema of their tongue, which could completely obstruct their airway, or it could be in the form of laryngeal edema, which will present as stridor, and in grade 3 patients, this stridor might be severe. It might cause respiratory distress, hypoxemia, hypoventilation, and severe agitation. And it could possibly even progress to the point of complete occlusion of the larynx and respiratory arrest.
So we have to intubate these patients early before they have complete occlusion of their larynx, or before you have a grade 4 view because the airway is so swollen you can't see anything. So that's what we're talking about. Airway edema can happen rapidly, progressively, complete obstruction, where your only option then is a front of neck airway. So we need to watch for mucosal edema and intubate these patients early. So indications for intubation: severe circulatory collapse, airway edema, and then the next indication would be hypoxemia and severe bronchospasm. And again, in the talk on ventilation, I talk about the indications for intubation in bronchospasm.
The treatment for bronchospasm in grade 3 anaphylaxis will be the same as the treatment in grade 2 anaphylaxis, except the patient may require continuous doses of rapid-acting beta-2 agonists, either via nebulization or using a meter-dose inhaler down the endotracheal tube.
These patients can also receive the hydrocortisone dose of 200 milligrams intravenously and a slow Phenergan dose of 25 milligrams intravenously. So just some special points to mention: that if you are suspecting anaphylaxis and you have hypotension with bradycardia, it's recommended that you don't give atropine in that situation because you can precipitate a ventricular arrhythmia. And it's better to give adrenaline boluses and intravenous fluids in that scenario. Other special situations are, it's been proposed that for rocuronium-induced anaphylaxis, maybe sugammadex, which is a donut-shaped molecule that actually binds rocuronium and it sort of sequesters it or hides the rocuronium from the rest of the body, that maybe that would resolve rocuronium anaphylaxis. But that hasn't been proven. And the case reports where sugammadex was given and there was immediate improvement, those patients were also receiving adrenaline and intravenous fluid. And it's difficult to know whether it was the adrenaline that made the improvement or the sugammadex. And so from my reading, there's no evidence to support giving sugammadex in that situation. And sugammadex is actually one of the drugs that's got quite a high incidence of anaphylaxis. So giving that drug in that situation could actually worsen the anaphylaxis.
At some point during this resuscitation, if you're able to do so, it would be ideal to insert an invasive arterial blood pressure catheter for continuous blood pressure monitoring, and then also to insert a central venous catheter so that one can run one's inotropes directly into the central veins in the chest. One of the core topics that is discussed in the anaphylaxis literature is the idea of refractory shock. And these are patients that are not responding to the adrenaline boluses and infusions and to the fluid therapy that one is instituting. And so these patients may need alternative treatments for their shock. But before assuming that it's the adrenaline infusion that is failing to make the patient improve, you need to consider other possible options too. And I found this reference from the Australian and New Zealand Anesthetic Allergy Group really useful. And you'll see that in my talk on safe anesthesia, I recommend compiling a flip folder in theatre with treatment algorithms for the management of anesthetic complications. And I would highly recommend putting the guidelines from this group in that folder. So, as I said before, assuming that it's a failure of response to adrenaline, you need to consider other options too. You need to consider hypovolemia. As I've said, these patients can have intravascular fluid deficits that are ongoing and that require up to a 5-liter intravenous volume resuscitation. And performing things like straight leg raise tests, pulse pressure variation assessments on arterial lines, and transthoracic echoes of the heart to look at ventricular filling can really help you in this assessment. Then you also need to consider ongoing exposure to the allergen. Maybe the patient isn't improving because there's ongoing stimulus, and these could be things like latex allergen. If you're using colloid fluids in your resuscitation, you need to stop them. And then if there's ongoing exposure to chlorhexidine solution, you need to wash that off the patient. And then you need to check that your adrenaline infusion hasn't malfunctioned. This could include disconnections, loose connections, and then also tissued intravenous lines where the adrenaline isn't actually reaching the bloodstream. And here again, if you have the facilities to put in a central line during the resuscitation, this can greatly improve the safety of your adrenaline infusion. You can also check that you mix the solution correctly, or perhaps even mix a new solution and try it on a different intravenous line. And then there's obviously the option of trying alternative inotropes, which, depending on your resources and your setting, may or may not be available. And then there's the option of ECMO. So the alternative inotropes that we can use in refractory shock, if you have access to noradrenaline, you can mix 1 ampule, which is normally 4 milligrams of noradrenaline, in 50 mils of 5% dextrose water. Don't mix it in normal saline. And you can start that infusion at 40 mils an hour, and then bolus and titrate as necessary. If you have access to vasopressin, you can give a 2-unit bolus and then start an infusion at 2 units per hour. For patients that are taking beta blockers that may be blocking the effectiveness of adrenaline, one can give glucagon boluses of 1 to 2 milligrams every 5 minutes or as needed. And then if you have no other options, you can try run a phenylephrine infusion, the standard mixture that we create in theater. And again, I would start that at about 30 mils an hour. In these scenarios, I would still continue my adrenaline infusion because I would want the benefit of adrenaline on stabilizing the mast cells and the basophils, and then also on treating the bronchospasm that the patient may be having. So those are alternative inotropes that can be used in refractory shock. Just to touch on ECMO, if you are working in a center that has ECMO, ECMO is something that can be considered as an emergency life-saving intervention, and place the patient on arteriovenous ECMO on an external heart-lung machine and hopefully give the patient a chance at survival.
Okay, so we've covered the management of grade 1 reaction, grade 2 reactions, grade 3 reactions. Grade 4 reactions are where patients now have cardiac arrest, and we would follow the normal CPR protocol, which includes adrenaline boluses. And then don't forget to give intravenous fluid, because these patients will almost certainly require intravenous fluid. Okay, so that's the management. Next question. So what is it that actually treats anaphylaxis? The answer is simple. It's adrenaline. Adrenaline is the agent that treats anaphylaxis. It's the agent that's going to save the patient's life. And that is because it stabilizes the mast cells on the basophils. So it stops them from further degranulation. It stops the process of releasing pro-inflammatory molecules into the circulation. And then it treats the cardiovascular collapse. By vasoconstriction, it increases your peripheral vascular resistance. It provides the squeeze on your arteries and your veins to increase blood pressure and then also increase venous return. On the heart, it increases cardiac output by increasing heart rate and contractility. So excellent cardiovascular effects in the face of anaphylaxis. It's then also a potent bronchodilator. There's no difference between giving intravenous salbutamol, so an intravenous beta-2 agonist, or giving intravenous adrenaline. Adrenaline works just as well as a bronchodilator. So it's going to treat your cardiovascular collapse and it's going to treat your bronchospasm. What about the other drugs? Well, there's no evidence supporting the use of steroids or H1 blockers or H2 blockers, but most people would still give them. So we give the steroids because of the theoretical benefit of reducing the chances of a long anaphylactic reaction or a second phase of anaphylaxis. So patients can improve and then deteriorate again 4 to 8 hours after the first reaction. We'll get into that when we talk about monitoring after the reaction. But steroids have that theoretical benefit of reducing the chances of that. It's not been proven. Then we give H1 blockers, which are antihistamines, to treat the skin itch, to make the patient feel better. But they can cause drowsiness and hypotension, especially when they're given intravenously. And the agent that I'm most familiar with would be Phenergan, and I would give 25 milligrams intravenously, but I would give it slowly over about 5 minutes so that I can manage and treat any hypotension. And then we give H2 blockers, which are antacid medications to reduce the GIT symptoms. Okay, so we've said that adrenaline is the treatment. That's what's going to save the patient's life. But what are the risks with giving adrenaline? Well, they're pretty obvious. If we give too much adrenaline or we give it inappropriately, we're going to see tachycardia, we're going to see hypertension, and I'm talking blood pressures of 250 over 150 if you give a big dose. Those patients will have a severe headache when their blood pressure is that high. We can cause arrhythmias. We can induce myocardial ischemia. In patients that are at risk of bleeding with a high blood pressure like that, we can induce bleeding from their vascular sites. And if they have other vascular issues such as aneurysms, brain aneurysms, aortic aneurysms, those aneurysms can rupture. So all these risks are worse if we make a drug error or we overdose the patient. And that is far more likely with intravenous treatment, because now we're taking 1,000 micrograms of adrenaline, which is 1 milligram, 1 ampule, and we have to dilute that so we can give the patient 50 microgram bolus or 200 microgram bolus. And if we make a mistake in that process, we're going to see all of these complications. And bearing in mind that we're not drawing up this adrenaline in a nice, relaxed, calm way, the patient is sick, they might be acutely unstable. We've got to manage multiple things: airway, breathing, circulation, and we're trying to draw up the adrenaline. So intravenous adrenaline has definitely got more risks, but in acutely unstable patients, it's also going to work much faster than the intramuscular adrenaline. So for grade 1 or grade 2 reactions, give intramuscular adrenaline. For grade 3 reactions, if you can't give intravenous adrenaline quickly and safely, give intramuscular adrenaline and then prepare for your intravenous treatment. Remember that the intramuscular adrenaline can be repeated every 5 minutes or as needed, and it's relatively safe. Okay, so what are the possible outcomes of these scenarios? So with early appropriate treatment, the outcomes are actually really good, and from my reading, it seems like the mortality associated with anaphylaxis is around 10%. In grade 1 patients that are having reactions in theatre, you should be able to proceed with the surgery while being vigilant for progression. In grade 2 reactions, you should pause the surgery and wait for the symptoms to resolve, have the whole team focus on what's going on with the anesthetic, and then decide whether to continue with the surgery or not. I would have a low threshold for abandoning the surgery because these grade 2 reactions can get worse and you don't know when that's going to happen. So if the patient is having life-saving surgery, proceed with the surgery, but otherwise I would abandon the surgery. And these patients I would keep in the recovery room for an extended period of time so that they can be under direct monitoring. So I would keep them for at least an hour. And then I would want to admit them to the surgical ward and monitor them there overnight. I wouldn't let these patients go home as a day case procedure. From my reading, I think that's a little bit of a gray zone, but just I would want to err on the side of caution. For grade 3 reactions now, which are acute life-threatening reactions, unless it is absolutely life-saving surgery that cannot wait, the surgery needs to be abandoned. The whole team needs to focus on stabilizing the patient, and then some of the patients one will be able to extubate or take off life support, and these patients I would then admit to the high care unit for continued observation and looking for organ dysfunction from their period of hypoxemia or hypotension. So monitoring their cardiac enzymes, monitoring their renal function and their urine output, and watching to make sure that they don't have complications or a reoccurrence of the anaphylaxis. But a significant number of these patients are actually going to need to go to ICU on life support, either ventilated or on adrenaline infusion or both. And then grade 4 reactions where the patient has had a cardiac arrest. These patients are almost certainly going to go to ICU on life support if you're able to get return of circulation. And I would recommend neuroprotecting them for 48 hours because they've had a cardiac arrest, and we want to allow any brain edema to reduce And they, like I say, they're going to need to go ventilated, probably on inotropes, to ICU. Okay, so we've now managed the anaphylactic reaction. How do we confirm the diagnosis of anaphylaxis? As I said at the beginning, there's quite a big differential diagnosis when a patient collapses, and we think this is anaphylaxis. We've managed it according to anaphylaxis principles, but how do we confirm the diagnosis? So the scientific papers talk of a 3-step approach. The first one is the clinical picture or the history that the patient gives you. We've spoken about that. The second step is laboratory testing, which is usually in the form of a mast cell tryptase level. And then the third step is follow-up confirmatory testing in the form of provocation tests. So these are normally skin tests. So you can do a skin prick test, or you can do an intradermal injection test, or you can even do an oral provocation test where the patient takes the drug orally and you see if there's a reaction. Okay, so just a little bit more on the mast cell tryptase level. If you can do it, it's really helpful that you do it. You need to draw the first set of bloods within 30 to 60 minutes of the onset of the anaphylactic reaction. And that's because the tryptase levels, which are released from the mast cells during the anaphylaxis, they peak at about 60 minutes, and then they start to go down. So if you draw the blood after 60 minutes, you might get a falsely low reading. We want to see what the peak level is. So you want to draw the bloods within the first hour. You then want to put them on ice, and they need to get to the laboratory and be tested as soon as possible. Because while the blood is awaiting, those levels are going to go down. So you need to take that blood and get it to the lab urgently. We then need to get a baseline tryptase level. And obviously we can't get a baseline from before the surgery or before the procedure because we didn't know that the anaphylaxis was going to happen. So we have to get it after the procedure, and we have to wait for everything to settle down before we do that. So the guidelines recommend waiting 24 hours, but you can wait even longer. I think the last time I did it, we did it on day 5, just to make absolutely sure that everything had settled and we were getting a true baseline reading. And then to interpret the results, the actual numbers are not important. You can look them up when you're in that situation. But we look at the absolute peak of the tryptase level, can look at the difference between the tryptase peak and the baseline, and then we can also look at the ratio between the two. And that will tell you how likely it is that it was an anaphylactic reaction. And then you've confirmed this was anaphylaxis. Then how do we confirm the actual offending drug? So this is a really big topic, and it's probably more for the immunologists. But what I do want to say is that in vitro testing, so testing in the lab, taking blood from the patient, sending it to the lab and getting them to test it for drug allergy, is not sensitive enough to rule out false negatives. So remember, a false negative is a patient who tests negative when they are actually positive in real life. So we test them to say, are you allergic to this drug? And the answer from the test is no. But in real life, the answer actually should be yes. It's a false negative. So there's a big danger in that, because we can label a patient non-allergic when they are actually allergic. So in vitro tests are not sensitive enough, and that's why the gold standard for allergy testing is in vivo testing, testing in the actual patient. And we do that by doing skin pricks on the skin or intradermal injections. And there's a whole science around which one is safer, how you prepare the drugs, what concentration you use, if there's no reaction, how you escalate the concentration of the drug with repeat testing until you get a reaction, how you interpret the results. And then for certain drug allergies, such as a penicillin allergy, one might still then even go onto oral provocation, where the patient has had negative skin prick and intradermal testing, but you still think that they're allergic, and then you can actually give them an oral penicillin and see if they have a reaction or not. So this testing is really, really important, but it needs to be done with people that have experience in how to do it. And then it obviously needs to be done in a monitored environment with full resuscitation equipment available. So I guess the take-home message from this is after you've safely got the patient through the anaphylactic reaction, you have a responsibility to the patient to try determine what the causative agent was. And you also have a responsibility to your colleagues who might be managing this patient in the future to determine what the agent was so that they're not in the same terrifying situation that you were in a year's time when the patient comes for their anesthetic or operation. Just as an aside on this topic, just remember to talk to your patients. We might be working in different resource settings where testing is or isn't available, but talking to the patient, you can still give them useful information. So at the most basic level, you could say, you had a reaction in theater to the anesthetic. I think it was an allergic or anaphylactic reaction. You need to tell future doctors that this happened. That's the most simple information that you can give, but it's still beneficial. You could take it one step further. You could say, we did blood tests, we did a tryptase level, and it confirmed that it was an anaphylactic reaction. So you can tell the doctors, I definitely had an anaphylactic reaction. You could take it even one step further still. You could say, these were the drugs that you were exposed to that I think could have been the culprits for your anaphylactic reaction. You had midazolam, sufentanil, and coamoxiclav, and then you had an anaphylactic reaction. So one of those three drugs caused the reaction. It's really important that you tell that to future doctors and future anesthetists. And then obviously, if you do actual drug testing, then you could counsel the patient and say, this is the drug that you are allergic to. You need to avoid it, but you also need to avoid some other drugs maybe. And we'll talk about that just now when we talk about cross-reactivity. Okay. So that now brings us to the last part of this video lecture, and that is discussing how we manage patients that report a drug allergy to us preoperatively in our pre-anesthetic check. So every day in my practice, I have patients tell me pre-op that they are allergic to certain medication. And my response is to ask a series of questions. I want to know, when did the event occur? Did it happen last week, last year, or is this something that happened 40 years ago? What were the symptoms when it happened, if the patients can remember? And I specifically ask about symptoms that I'm worried in. Shortness of breath, tight chest, tight throat, eye swelling, rash. I ask the patients how long after taking the medication did the episode occur, and if they can remember that, they can tell me. And then I ask them, well, what did you do about it? Did you go and see your general practitioner? Did you go to the emergency room? Did you get admitted to ICU or high care? Did you need life support? Were you given adrenaline? Because that also tells me how severe the reaction was. And it usually quite quickly becomes evident that most of the reported allergies are not allergies at all. They are recognized side effects of the medication that the patient was taking. For example, nausea and constipation caused by multiple drugs. You can have dysphoria with certain opioids. Patients often complain about dizziness when they're using anti-inflammatory drugs. Patients complain about itching when they're given morphine intramuscularly or intravenously. And then lots of antibiotics can cause diarrhea or dyspepsia when you take them orally. These are not allergic reactions, and I reassure the patients that they are not allergic reactions and they are experiencing the adverse side effects of the medication. I still do try to avoid these medications for these patients because I don't want them to have these unpleasant symptoms where possible, but often it's not possible. And then I give the medications and we try and manage the symptoms as they come along. So sometimes though, when the patient says they're allergic to a medication, it actually sounds more serious, like it could be an allergic reaction. And then the principle is that it's best to stay away from that medication altogether. But it isn't always that simple. So let's talk about 5 of the most common reported allergies that I encounter in my practice, and we'll go through some of the details. So those are penicillin, morphine, local anesthetics, sulfur drugs, and then we do have to say something about the non-depolarizing muscle relaxants. So starting off with penicillin. So penicillin is the most commonly reported allergy worldwide. And most often the patient reports having a reaction as a child for which they can't remember the details, but they were told by someone that they are penicillin allergic. So it's estimated that roughly 90% of reported penicillin allergies are in fact not allergies. Penicillin allergy also resolves with time. So patients that were allergic over time become non-allergic. The CDC website says that 80% of penicillin allergic patients are no longer allergic after 10 years. So this is even if the penicillin allergy has been confirmed on a skin prick test, that 80% of those patients after 10 years will no longer be penicillin allergic. So you may be asking, well, penicillin's use is really declining in medicine due to resistant patterns. So why are we so worried about penicillin allergy when we hardly ever use it in theatre? So the main concern as anesthetists about penicillin allergy is actually the cross-reaction with other antibiotics. And those are the cephalosporins and the carbapenems. And they're a big part of either prophylactic antibiotic therapy in theatre or therapeutic antibiotic therapy in the hospital setting. So in other words, a patient with a true penicillin allergy may also be allergic to a cephalosporin or a carbapenem, and that's a big deal. This risk is about 1 to 8% cross-reactivity with patients who have true penicillin allergy. So this is really important for us because the most commonly used antibiotic in theatre for surgical site prophylaxis is cefazolin, which is a first-generation cephalosporin. And the studies that come from the USA show that for anaphylaxis in theatre, cefazolin is the most common causative agent. Okay, so we've covered some details on penicillin allergy, and then we've said, well, we don't use penicillin that often, so what's the big deal? And then we said, well, we're worried about can we use cephalosporins and carbapenems? And we said, well, maybe we can't because there's cross-reactivity. So you might ask again, but why the big fuss? Why not then just use a different antibiotic altogether from another class, something that isn't a penicillin or a carbapenem or a cephalosporin, such as clindamycin? It's got excellent gram-positive cover. But the answer isn't that simple because the alternatives are not always as effective. So for example, if we use cefazolin in joint replacement surgery, the risk of a joint infection is half the risk than if we use an alternative antibiotic. So not using cefazolin doubles the risk. And if you've ever worked in an orthopedic theatre where they're doing joint replacements, you'll know that everyone is worried about sepsis. The sterility is meticulous, there's laminar flow, there's a cold theatre, the surgeons wear, full body suits and hoodies. We are terrified of joint infection. And now we're saying if we don't use cefazolin and we use something else, vancomycin or clindamycin, the risk of joint sepsis doubles. That's a really big deal. Okay, so that's when we're talking about prophylaxis. And then if we're talking about therapeutic antibiotic cover, well, the alternative antibiotics might not be as effective. They might not have as good tissue penetration, and they might not actually cover the organism that we're trying to treat. So avoiding cephalosporins and carbapenems completely also carries significant risks. So how do I navigate this practically and clinically? So if the patient reports a penicillin allergy that happened quite some time ago, more than 10 years ago, or they can't remember the details, the history is quite vague, or they say they just had a rash but they had no other symptoms, in those patients, I will avoid giving them penicillins. But in terms of antibiotics in theatre for surgical site prophylaxis, I will still use the cephalosporins and I'll give them a dose of cefazolin. Obviously, every time I'm in this situation, as I'm giving that antibiotic, I'm aware of the risk benefits and I am prepared to manage anaphylaxis if it occurs. For these patients, actually just thinking one step back, before they come to theatre, in most cases, I counsel them and I tell them, it doesn't sound like your penicillin reaction was a severe life-threatening reaction. There can be cross-reactivity with some of the antibiotics that we use in theatre, but the risks of that are relatively low. And the antibiotics that we want to use are the best antibiotics for the benefits that we want in theatre. And so I've taken informed consent. For patients that give a more significant history of penicillin allergy, I will avoid penicillin, and I'll also not give the cephalosporin as a surgical site prophylactic antibiotic, and I'll use a drug like clindamycin. So just as an aside, this isn't the focus of this talk. When it comes to the use of therapeutic antibiotics, it becomes a lot more difficult. So if you have a patient that picks up a nosocomial pneumonia and they're sick now, they're on oxygen, they're in a high care setting, and you want to give them a carbapenem to treat that pneumonia, and they're saying that they have a penicillin allergy, well, then the risk-benefit analysis becomes far more difficult. And it also depends on whether you're treating empirically or whether you have sensitivities back. And that's a very difficult situation to be in as a clinician, but that's a separate talk, but it is something for you to think about in the background. Okay, so that's the summary for penicillin allergy. Next, let's move on to sulfur allergy. So sulfur allergy is again an allergy where there's some uncertainty. If you read on it, or from my reading, you'll see that there's certain drugs that are definitely contraindicated in sulfur allergy, and examples would be the two antibiotics, Bactrim and Dapsone. But then the studies give lists of drugs that do have sulfur compounds in them, but are thought to be safe or have a much lower risk of inducing a sulfur allergy.
The two drugs that I have to think about in my anesthetics are the two COX-2 selective nonsteroidal anti-inflammatory drugs. Firstly, celecoxib, which is an oral formulation, and then parecoxib, which is an intravenous formulation.
And then also furosemide or Lasix, the loop diuretic used very commonly in hospitals. That's got a sulfur element. And then the blood pressure treatment hydrochlorothiazide has also got a sulfur element. And those drugs are much lower risk, but it's a gray zone whether you can use them or you can't use them. So in patients that report sulfur allergy, I obviously stay away from the antibiotics that are contraindicated. And then I also don't use celecoxib or parecoxib. I'll rather use a non-specific agent. And then if I'm worried about gastritis or gastric ulceration, then I'll prescribe an antacid like a PPI. So that's sulfur allergy. Next up, we come to morphine allergy. So I've had quite a few patients report problems with morphine during my preoperative assessment. Most of the time, patients talk about the itch that you get after being administered intravenous morphine. That's not an allergic reaction. That's local histamine release in the vein, and that's not anaphylaxis. They also complain about nausea, vomiting, constipation. Some patients complain about dysphoria. I've had quite a few patients who've had what sounds like morphine overdose or problems with doses of morphine that are too high in the ward. But then every now and then a patient will report a morphine reaction that does actually sound like an allergy or an anaphylaxis. Tight chest, difficulty breathing, heaviness on the chest, or they woke up in ICU. It's difficult to know if they're allergic. So what do we do in that situation? Well, there are different classes of opioids, and morphine, codeine, and oxycodone are all in the same class. So we want to avoid those three drugs in patients that report a morphine allergy. But fortunately, pethidine and the synthetic opioids like fentanyl, sufentanil, alfentanil, and remifentanil, they are from a different class. And so we can safely use those drugs. And that's what I do in these situations. Right. So then the next allergy that I come across is local anesthetic allergy. Patients say to me, they were at the dentist, they had a reaction, and the dentist said they must be allergic to local anesthetics. And when I ask my questions around anaphylaxis, what it sounds like is the patient had a hot feeling, they had palpitations, they had a racing heart, sometimes they had a headache or heaviness in the heart. And it's really difficult to actually know what's going on there. There's a couple of things that could be happening. So it could be local anesthetic toxicity. The local anesthetics are being injected into a very vascular mucosa in the mouth, and there could be a high systemic concentration of those drugs, and it could be some local anesthetic toxicity. Often the local anesthetics that they use in dental work contain adrenaline because you don't want bleeding of the gums. And again, it's a very vascular area, so maybe there's systemic absorption of that adrenaline. And then we see those adrenaline effects, tachycardia, palpitations, arrhythmias, high blood pressure. Then it could be a true local anesthetic allergy, although allergy to the amide local anesthetics, which are the ones that we now use in modern anesthesia, lignocaine, bupivacaine, ropivacaine, the risk of anaphylaxis with amide local anesthetics is much less than the ester group. And then if the local anesthetics are coming from a multi-dose vial, then it could be an allergic reaction to the preservative in that multi-dose vial, which is methylparaben. So it's quite difficult to actually know what's going on. And then often I ask the patients, well, what did you do? How was it managed? And they'll say, oh, well, no, the symptoms just went away on their own. It just improved on their own. And I say, so they didn't call a paramedic, you didn't go to see your GP, you weren't referred to the emergency room, you weren't given adrenaline. And they're like, no, none of that. It just got better on its own. So that again, to me, sounds less like anaphylaxis. And so for these patients, it's risk benefit again, but I must say that I tend to continue with my local anesthetic use, whether I'm doing nerve blocks or intraperitoneal injection of local anesthetic for laparoscopic surgery. I think that the benefits of multimodal analgesia and avoiding high-dose opioids and those benefits outweigh the risks of quite a vague history. And then lastly, let's talk about the non-depolarizing muscle relaxants. So I've never had a patient tell me preoperatively that they are allergic to a non-depolarizing muscle relaxant. I've had a few patients that have come from families that have had scoline apnea, and I've had a few patients that have got malignant hypothermia, but I've never had a patient say, I can't have a muscle relaxant because of allergy. But it is one of the most common drugs to induce anaphylaxis in theater, so I do think we need to talk about it. And really the big question here is if you have a patient that is allergic to rocuronium, or you have a patient that has a history of anaphylaxis in theater, but it was never confirmed what the drug was, and so now you want to avoid the use of rocuronium and vecuronium, what are you going to use? So the best drug to use in these scenarios, the safest drug, is cis-atracurium because it's got the lowest rates of cross-reactivity in patients who have had previous anaphylaxis to rocuronium and vecuronium. And that was determined in a study by Sadlier, Clark, Bunning, and Platt, which was called Anaphylaxis to Neuromuscular Blocking Drugs, Incidence and Cross-Reactivity in Western Australia. So there are obviously lots of other potential drugs or chemical allergies that we can come across in theater. Then there's also the risk of cross-reactivity in patients with certain food allergies, but there's just too much detail to go onto and it would make the talk too long. So the take-home message is that when you come across a reported drug allergy, the safest and simplest option is to avoid that drug or allergen altogether. And then if you want to know if you can use similar drugs or if there's cross-reactivity, well then you have to turn to the literature. And this is what I do in my practice. I will then Google what drugs are safe to use in someone who is allergic to diclofenac, or what drugs are safe to use in someone who's allergic to morphine, and then try find a review article or a publication that you can read and then plan your anesthetic that way. There's obviously lots of drugs out there, lots of potential for anaphylaxis and for patients that report reactions. And the only way to know is to read at each time. Right, so that concludes this talk on the management of perioperative anaphylaxis. I hope it's been beneficial for you. It certainly has been excellent for me to go through this information again and to have a fresh understanding of how I'm going to manage my next anaphylactic reaction. And as always, your feedback is welcome. We really want to improve the quality of these talks. And take care and good luck.